Block simulation 40. Same process, fresh set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Which statement about bone remodeling is correct? A physiologist studies how bone is continuously remodeled by osteoblasts and osteoclasts. Read the command. Which bone remodeling statement is correct? Osteoblast build, osteoclast resorb, rankle, activates osteoclast, OPG, decoy blocks rankle, PTH or VITE-D modulate, estrogen restrains resorption. Bone is constantly remodeled by two cell types in balance. OST or blast build bone. They synthesize osteoid, type 1 collagen matrix, and then mineralize it. Some become embedded as osteocytes. OST-eoclast, large multinucleated cells derived from the monocyte E or macrophage lineage, or E-sorb bone. They secrete acid and enzymes and produce tartrate-resistant acid phosphatase. The key regulatory point, OST-eoblasts actually control osteoclast activity through the rankle and OPG system. The correct answer is E. The rankle and OPG axis is high yield. Osteoblasts express rankle receptor activator of NF-kappa B ligand, which binds rank on osteoclast precursors to drive their differentiation, and acetylation leads to bone resorption. Osteoblasts also secrete OST-eoprogesterone OG, a decoy receptor that binds rankle and prevents it from activating osteoclasts. So OPG inhibits resorption, some K and high N. O prevents it from activating osteoclasts, so OPG inhibits resorption. Hormones tune this. PTH, intermittent, and vitamin D modulate remodeling, and estrogen restrains osteoclasts. Its loss in menopause leads to increased resorption or osteoporosis. The drug denosumab is a monoclonal antibody against rankle, mimicking OPG used for osteoporosis. The osteoblast builds or osteoclast resorbs with rankle activates or OPG blocks. Framework is correct. What is the diagnosis and the murmur? A child is found to have a holosystolic murmur best heard at the left lower sternal border. Echo shows a defect in the interventricular septum with a left to right shunt. Most small ones close spontaneously. Large ones can lead to Eisenmenger syndrome. Read the command, diagnosis and murmur. Holosystolic murmur at LLSB. Interventricular septal defect, left to right shunt, ventricular septal defect. This is a ventricular septal defect, VSD, the most common congenital heart defect. It is an opening in the interventricular septum which creates a left to right shunt. Blood flows from the higher pressure left ventricle into the right ventricle. Because it's a left to right shunt, it is acyanotic initially. The correct answer is C. The classic murmur is a holos, systolic, pansystolic murmur, best heard at the LEF lower, sternal border. Interestingly, smaller VSDs make louder murmurs, more turbulence. The clinical course, small VSDs are common and often close spontaneously. Large unrepaired VSDs cause a big left to right shunt leads to pulmonary overcirculation, heart failure, and over time, pulmonary hypertension, which can eventually reverse the shunt to right to left, Eisenmenger syndrome, causing cyanosis. VSD is associated with fetal alcohol syndrome and Down syndrome. The holosystolic left lower sternal border murmur from an interventricular septal defect is a VSD. Which statement about GAGs or proteoglycans is correct? A biochemistry student studies glycosaminoglycans, GAGs, and proteoglycans of the extracellular matrix. Read the command. Which GAG or proteoglycan statement is correct? GAGs is long negatively charged polysaccharides on core protein leads to proteoglycans. Attract water, hydration or cushion or GBM charge. Breakdown fails in mucopolysaccharidoses. GLY-cosaminoglycans, GAGs, are long, unbranched polysaccharide chains made of repeating disaccharide units that are heavily sulfated and carboxylated, making them strongly negatively charged. Examples include heparan sulfate, chondroitin sulfate, dermatan sulfate, keratin sulfate, and hyaluronic acid. When GAGs are attached to a core protein, they form proteoglycans. Major components of the extracellular matrix and ground substance. The correct answer is B. The high-yield functions follow from the negative charge. GAGs attract cations and water, giving tissues their hydration and turgor, providing the compressive cushioning of cartilage and synovial fluid lubrication, hyaluronic acid, and contributing the negative charge barrier of the glomerular basement membrane, heparan sulfate. Clinically, GAGs are degraded in lysosomes, and inherited deficiencies of the degrading enzymes cause the mucopolysaccharidosis, Hurler, alpha L-iduronidase, and Hunter iduronate sulfatase, where GAGs accumulate, causing coarse features, organomegaly, and developmental problems. Heparin, a GAG, is also the anticoagulant. The negatively charged, water-attracting proteoglycan GAGs whose breakdown fails in mucopolysaccharidosis GAGs whose breakdown fails in mucopolysaccharidosis is correct. Which statement about the pectinate line is correct? A surgeon operating on the anal canal must respect the pectinate dentate line. Read the command which pectinate line statement is correct. Above is endoderm, visceral or insensate, portal drainage, internal hemorrhoids, painless, adenocarcinoma. Below is ectoderm, somatic or painful, systemic, external hemorrhoids, SCC, inguinal nodes. The pectinate dentate line is a critical embryologic and clinical boundary in the anal canal. It marks where the endodermal hindygut meets the ectodermal proctodeum, and structures differ completely above versus below it. Above the pectinate line, derived from endoderm hindygut. Visceral, autonomic, innervation, so it is relatively iron sensate, pain insensitive. Venous drainage via the superior rectal vein into the portal system. Internal hemorrhoids form here and are painless, and cancers here are adenocarcinoma. Lymph drains to internal iliac nodes. Correct answer is C. Below the pectinate line, derived from ectoderm. Somatic innervation via the inferior rectal branch of the pudendal nerve, so it is pain sensitive, painful. Venous drainage via the inferior rectal vein into the SY stomach circulation, IBC, via internal pudendal or internal iliac. External hemorrhoids form here, and ARE painful. Cancers here are squamous cell carcinoma, and lymph drains to the superficial inguinal nodes. This is why an anastomosis exists. Portal systemic, internal or external hemorrhoids, and portal hypertension. The above visceral or portal or painless internal hemorrhoid versus below. Somatic or systemic or painful external hemorrhoid distinction is correct. Which set of complications of chronic kidney disease, uremia, is correct? A patient with end-stage renal disease on the path to dialysis develops a constellation of complications from accumulated toxins and failed kidney functions. Read the command which CKD or uremia complication set is correct. Hyperkalemia, metabolic acidosis, fluid overload or HTN, anemia, decreased EPO, renal osteodystrophy, decreased VIT-DD+, hyperphosphatemia leads to secondary hyper-PTH, uremic encephalopathy or pericarditis, bleeding. Chronic kidney disease, CKD, when advanced, produces uremia, a syndrome from retained toxins and lost kidney functions. The electrolyte, acid-base derangements, hyperkalemia, failed potassium excretion, metabolic acidosis, failed acid excretion or bicarbonate loss, anion gap, and sodium and water retention causing fluid overload and hypertension. These reflect the kidney's lost excretory role. The correct answer is A. The hormonal or synthetic failures are equally high yield. Anemia develops because the kidney makes less erythropoietin, normocytic anemia, treated with EPO. Renal osteodystrophy, CKD mineral bone disease, arises because the kidney fails to activate vitamin D. Low 1,2,5 vitamin D leads to low gut calcium absorption, leads to hypocalcemia, and fails to excrete PHOS bisphate, hyperphosphatemia, which also binds calcium. The resulting hypocalcemia drives secondary hyperparathy, iridorism, and bone disease. Uremic toxins also cause uremic encephalopathy, pericarditis, nausea, pruritus, and platelet dysfunction, bleeding. The hyperkalemia or acidosis, anemia, and renal osteodystrophy complication set is correct. Which statement is correct? A physiologist studies the hypothalamic pituitary adrenal HPA axis. This question targets the diurnal rhythm and the dexamethasone suppression test, not cortisol's tissue effects. Read the command. Which HPA or diurnal or dexamethasone statement is correct? CRH leads to ACTH leads to cortisol, negative feedback. Diurnal, PKM, trough midnight. Dexamethasone suppression test probes feedback, Cushing localization. This revisits the HPA axis from the rhythm or testing angle. The axis, the hypothalamus secretes CRH, corticotropin-releasing hormone, stimulates the anterior pituitary to release ACTH, stimulates the adrenal cortex to secrete cortisol. Cortisol then exerts negative feedback on both the pituitary ACTH and hypothalamus CRH, keeping the system in balance. Cortisol secretion follows a diurnal, circadian, RHY, highest in the early morning, around awakening, and lowest around midnight. The correct answer is B. The dexamethasone suppression test exploits a feedback loop to evaluate Cushing syndrome. Dexamethasone is a potent synthetic glucocorticoid that, in a normal axis, suppresses ACTH and therefore cortisol. In the low dose test, a normal person or stress or exogenous causes suppresses cortisol. Failure to suppress suggests pathologic hypercortisolism, Cushing. The HIGH dose test then helps localize the cause. A pituitary ACTH secreting adenoma, Cushing disease, usually suppresses with high dose, retains some feedback, whereas ectopic ACTH or adrenal tumors do not suppress. The CRH ACTH cortisol axis with its morning peak diurnal rhythm and the feedback-based dexamethasone test is correct. Which immunosuppressant mechanism bearing is correct? A kidney transplant patient is on immunosuppressants to prevent rejection. Read the command. Which immunosuppressant pairing is correct? Calcineurin inhibitors, cyclosporine or tacrolimus, leads to block IL-2, nephrotoxic, mTOR, sirolimus, azathioprine or mycophenolate, purine synthesis, glucocorticoids, basiliximab, anti-IL-2R. Transplant immunosuppression combines drugs that hit different points of T-cell activation. Calcineurin inhibitors. Cyclosporine binds cyclophilin and tacrolimus, binds FKBP, inhibit calcineurin. Blocking the transcription of IL-2 leads to less T-cell activation or proliferation. They are cornerstones of transplant regimens but are NEPRO2-XE and cyclosporine causes gum hyperplasia or hirsutism. Tacrolimus causes neurotoxicity or diabetes. The correct answer is D. The other classes, mTOR-I inhibitors, sirolimus, rapamycin, block the T-cell's response to IL-2, cell cycle progression, not nephrotoxic but cause hyperlipidemia and impaired healing. Antiproliferative or antimetabolites. Azathioprine leads to 6-mercaptopurine. Watch the interaction with allopurinol or xanthine oxidase. And mycophenolate inhibits IMP dehydrogenase, leads to blocks purine or guanine synthesis, suppress lymphocyte proliferation, bone marrow suppression, GI toxicity. Glucocorticoids broadly suppress, inhibit NF-kappa B or cytokines. Monoclonal antibodies like basiliximab block the IL-2 receptor, induction therapy. The calcineurin inhibitor, IL-2 block, nephrotoxic versus mTOR and anti-proliferative agents is the correct mapping. Which statement is correct? A woman with a breast mass is evaluated. This question targets the histologic types of breast cancer and key clinical patterns. Read the command. Which breast cancer type statement is correct? DCIS. Pre-invasive. Invasive ductal most common. Invasive lobular, single file, bilateral, ECAT heron loss. Inflammatory, dermal lymphatics, P. d'Orange. Paget nipple. This revisits breast cancer from the histologic type angle. Ductal carcinoma. In situ, DCIS, is a pre-invasive, non-invasive malignancy. The cancer cells are still confined by the basement membrane, often detected as microcalcifications on mammography. A commotile subtype has central necrosis. Invasive ductal carcinoma is the most common invasive breast cancer, a firm, irregular, hard mass with a desmoplastic fibrotic reaction. The correct answer is B. Invasive lobular carcinoma grows as cells in a single file, Indian file, pattern due to loss of Ecadherin, and is more often bilateral and multifocal. Inflammatory breast cancer is an aggressive presentation where tumor invades the dermal lymphatics. Blocking drainage leads to a swollen, erythematous, warm breast with PEA d'orange, orange peel skin. It has a poor prognosis and is often mistaken for mastitis. Paget disease of the breast presents as an eczematous, scaly nipple lesion, indicating underlying ductal carcinoma. Receptor status, ER and PR or HER2, guides therapy. The DCIS, pre-invasive, ductal common, lobular, single file, inflammatory PU d'orange typing is correct. Which organisms are these? 2 patients have filamentous, branching gram-positive bacteria. Patient A has a slowly progressive jaw abscess with draining sinus tracts containing yellow, sulfur granules after dental work, anaerobe, normal oral flora. Patient B, immunocompromised, has a pulmonary infection with partially ACI seed-fast organisms. Read the command. Which organisms? Jaw abscess plus sulfur granules, anaerobe, not acid-fast, is actinomyces. Pulmonary, partially acid-fast, immunocompromised is nocardia. These are actinomyces and nocardia, 2 filamentous branching gram-positive bacteria that are a classic compare and contrast. Actinomyces, patient A, is an anaerobe and part of the normal oral and GI flora. It is not acid-fast. After dental trauma or work or poor dentition, it causes cervical factual actinomycosis, a slowly progressive lumpy jaw, abscess that forms draining sinus, tracts containing yellow, sulfur granules colonies. It is treated with penicillin. The correct answer is A. Nocardia, patient B, is the opposite on each axis. It is an aerobe found in soil, and it is partially, weakly, acid-fast. It causes disease mainly in immunocompromised hosts and those with chronic lung disease, pulmonary nocardiosis, cavitary pneumonia that can disseminate to the brain, CNS abscesses, and skin. It is treated with sulfonamides, TMP-SMX. A memory aid, treat actinomyces with penicillin, Alise-to-P, and nocardia with sulfa, using the SNAP, sulfonocardia, actinomyces, penicillin. So, anaerobic, not acid-fast, oral, sulfur granule, penicillin treated is actinomyces. Aerobic, partially, acid-fast, soil, pulmonary or CNS, sulfo treated is nocardia. Which statement about lactation is correct? A physiologist studies lactation and the hormones controlling milk production and ejection. Read the command. Which lactation statement is correct? Prolactin is milk production inhibited by dopamine. Estrogen or progesterone blocked during pregnancy, fall after delivery. Oxytocin is milk ejection or letdown. Suckling stimulates both. Prolactin suppresses ovulation. Lactation is controlled by 2 pituitary hormones with distinct roles. Prolactin from the anterior pituitary drives milk production and synthesis in the mammary alveoli. Prolactin is unusual in being tonically inhibited by dopamine from the hypothalamus, so dopamine antagonists or antipsychotics raise prolactin. Dopamine agonists like bromocriptine or cabergoline suppress it. During pregnancy, high estrogen and progesterone prepare or grow the breast tissue but actually block the milk-producing effect of prolactin, which is why copious milk doesn't flow until after delivery. The correct answer is E. After delivery, the sharp fall in estrogen or progesterone, placenta gone, plus suckling removes the block and stimulates prolactin leads to lactation begins. Oxytocin from the posterior pituitary causes the milk ejection, letdown reflex. It contracts the myoepithelial cells around the alveoli to squeeze milk into the ducts. Suckling is the key stimulus for both. It triggers prolactin production and oxytocin ejection release. Oxytocin can also be triggered by the sight or sound of the baby. Finally, high prolactin suppresses NRH, leads to reduced LH and FSH in ovulation. Lactational amenorrhea, a natural, if imperfect, contraceptive. The prolactin makes milk and oxytocin ejects. Milk framework is correct. What is the diagnosis? A young woman has fatigue, jaundice, and elevated transaminases. She has other autoimmune conditions. Labs show positive anti-smooth muscle antibodies and/or anti-LKM1 and elevated IgG. Biopsy shows interface hepatitis with a lymphoplasmacytic infiltrate. It responds to steroids. Read the command. Diagnosis. Young woman, autoimmune, anti-smooth muscle or anti-LKM1, high IgG, interface hepatitis, steroid responsive, autoimmune hepatitis. This is autoimmune hepatitis, AIH, a chronic immune-mediated inflammation of the liver, hepatocyte-directed. It predominantly affects women and often coexists with other autoimmune diseases. It can present with fatigue, jaundice, and elevated transaminases, a hepatocellular or hepatitic pattern ranging from asymptomatic to acute or fulminant, and can progress to cirrhosis if untreated. The correct answer is D. The diagnostic clues are high yield. Serology, type 1. AIH is associated with anti-smooth muscle antibodies and ANA. Type 2, younger patients with anti-LKM1, liver-kidney microsomal antibodies, along with elevated IgG, hypergammaglobulinemia. BIOPSY shows interface hepatitis, periportal lymphoplasmacytic inflammation, eroding the limiting plate, with prominent plasmacytic inflammation. The key clinical feature is that it responds to Iammunus. Corticosteroids, prednisone, plus or minus azathioprine. Distinguished from primary biliary cholangitis, antimitochondrial antibody, cholestatic intrahepatic ducts, and viral or alcoholic hepatitis. The anti-smooth muscle or anti-LKM1, high IgG interface, hepatitis, steroid responsive liver disease. Which statement about the meninges is correct? A patient with head trauma is evaluated for intracranial bleeding, and the anatomy of the meninges and potential spaces is reviewed. Read the command, which meninges statement is correct. Dura or arachnoid or pia. Epidural is arterial, middle meningeal, biconvex, no cross sutures, lucid interval. Subdural is venous, bridging, crescent, crosses sutures. Subarachnoid is CSF space, aneurysm. The medians from outermost to innermost are the dura mater, tough, the aarachnoid mater, and the pia mater, adherent to the brain, with a subarachnoid space containing CSF between arachnoid and pia. The potential spaces give rise to characteristic hematomas. An epidural hematoma lies between the skull and dura. It is classically arterial from rupture of the middle meningeal artery, often with a temporal bone fracture. On CT, it is a lens-shaped, biconvex collection that does not cross suture lines. The dura is tightly attached as sutures, and it classically has a lucid interval, brief recovery before rapid deterioration as it expands. The correct answer is B. A subdural hematoma lies between the dura and arachnoid. It is venous, from torn bridging venizidigi, from acceleration, deceleration, or shaking, or trivial trauma in the elderly and alcoholics whose brains have atrophied, stretching the veins. On CT, it is senescent-shaped, concave, and crosses suture lines, but not the midline or dural reflections, often with a slower, more insidious course. A subarachnoid hemorrhage is bleeding into the CSF-filled subarachnoid space, classically from a ruptured berry aneurysm, worst headache of my life, thunderclap. The arterial biconvex epidural versus venous crescent subdural distinction is correct. Which statement about end-of-life decision-making is correct? A terminally ill patient with decision-making capacity has a living will declining intubation. Later, while unconscious, his family disagrees with the document. A separate patient has a designated healthcare proxy. Read the command, which end-of-life statement is correct. Advanced directive or living will plus healthcare proxy govern when capacity lost. Proxy other family. Competent patient may refuse treatment. Withdrawing care per wishes is ethical. End-of-life decisions are governed by the principle of patient autonomy. The patient's own wishes take priority. A patient with decision-making capacity may always refuse any treatment, including life-sustaining interventions, intubation, dialysis, feeding, even if refusal leads to death. Forcing treatment violates autonomy. When the patient loses capacity, their previously expressed wishes still govern, communicated through advance directives. The correct answer is D. The instruments, a living will, a written advance directive, specifies what treatments the patient does or does not want. A designated health care. Proxy or durable power of attorney for healthcare names. A person to make decisions using substitute judgment, what the patient would have wanted. And designated proxy's decisions generally take precedence over the opinions of other family members who disagree. So a family's objection does not override a valid advance directive or the proxy. Withholding or withdrawing life-sustaining treatment in accordance with the patient's wishes is ethical and legal. It is allowing the disease to take its course, distinct from euthanasia or physician-assisted death. The autonomy-driven advance directive or proxy governed right to refuse framework is correct. Which statement about insulin synthesis is correct? A biochemistry student studies how insulin is synthesized and processed in the pancreatic beta cell. Read the command. Which insulin synthesis statement is correct? Pre-proinsulin leads to proinsulin leads to insulin plus C-peptide equal co-secreted. C-peptide high is endogenous, low is exogenous insulin. Insulin synthesis in the pancreatic beta cell proceeds through precursors. It starts as preproinsulin, translated on the ribosome, which loses its signal peptide to become proinsulin in the endoplasmic reticulum. Proinsulin is then cleaved in the secretory granules into the mature I-insulin molecule plus the connecting C-peptide. Importantly, insulin and C-peptide are stored together and secreted in equimolar amounts whenever the beta cell releases insulin. The correct answer is E. The high-yield clinical application is C-peptide as a marker of endogenous insulin production. Because the beta cell co-secretes insulin and C-peptide together, a HIGH C-peptide indicates the body is making its own insulin, e.g. an insulinoma or sulfonylurea used which stimulates beta cells. In contrast, I-injected exogenous insulin contains no C-peptide dissociation with hypoglycemia from surreptitious or factitious insulin injection or accidental overdose has high insulin but low C-peptide. This insulin or C-peptide dissociation is the key to the hypoglycemia workup. The pre-proinsulin leads to proinsulin leads to insulin. Plus C. Peptide processing with C-peptide as an endogenous marker is correct. Which statement about testicular non-seminomatous germ cell tumors is correct? A 25-year-old man has a painless, firm testicular mass. Serum AFP and/or beta-HCG are elevated. Biopsy shows a non-seminomatous germ cell tumor. Read the command. Which non-seminoma statement is correct? Non-seminomatous yolk sac leads to AFP. Choriocarcinoma leads to HCG, more aggressive. Seminoma radiosensitive, usually marker, negative. Testicular cancer is the most common solid malignancy in young men, 15-35, usually presenting as a painless, firm testicular mass. Germ cell tumors split into seminomas and non-seminomatous germ cell tumors, NSGCTs, and the non-seminomas are generally more aggressive, earlier metastasis, but still very treatable. A key feature of NSGCTs is that they often secrete tumor markers, useful for diagnosis and monitoring. The correct answer is A. The marker associations are high-yield yolk sac endodermal sinus tumor, the most common testicular tumor in young children, secretes alpha-fetoprotein, AFP, Schiller, Duval bodies on histology. Choriocarcinoma secretes beta-HCG and can cause hyperthyroidism or gynecomastia, spreads hematogenously. Embryonal carcinoma is aggressive, may raise AFP and/or HCG. Choriocarcinoma is aggressive, may raise AFP and/or HCG. Cheller. By contrast, seminoma, the most common single type in slightly older men, is radiosensitive with an excellent prognosis and is usually marker negative. It does not make AFP. A seminoma that produces AFP is actually a mixed or non-seminomatous tumor, though it may mildly raise HCG, so AFP elevation rules out pure seminoma. The yolk, sac, AFP, choriocarcinoma, HCG, and more aggressive non-seminoma facts are correct. Which statement about phosphate handling is correct? A physiologist studies how serum phosphate is regulated, including the hormone FGF23. Read the command. Which phosphate handling statement is correct? PTH decreased renal phosphate reabsorption, phosphaturia. Vitamin D increased gut absorption. FGF23 increased excretion plus decreased vitamin D activation. Excess FGF23 leads to hypophosphatemia. Serum pHOSPATE is regulated by three hormones acting on the gut, kidney, and bone. Parathyroid hormone, pH, decreases renal phosphate reabsorption. It inhibits the proximal tubule, sodium phosphate cotransporter, leads to pHOSPATuria, lowering serum phosphate, even as PTH raises serum calcium. Active vitamin D increases intestinal absorption of phosphate and calcium, raising serum phosphate. The correct answer is E. FGF23, fibroblast growth factor 23, is the high-yield phosphotonin secreted by osteocytes or osteoblasts in bone when phosphate is high. FGF23 does two things. Both lowering phosphate, it increases renal phosphate excretion, also inhibits the sodium phosphate cotransporter, and a DEC raises the activation of vitamin D, inhibits 1-alpha hydroxylase, and stimulates its breakdown, which further reduces gut phosphate and calcium absorption. So EXCS FGF23 causes hypophosphatemia and rickets or osteomalacia, e.g. XCS FGF23 causes hypophosphatemia and rickets or osteomalacia, e.g. X-linked hypovation of vitamin D, inhibits 1-alpha hydroxylase, a papa hydroxylase, and stimulates its breakdown. In chronic kidney disease, the kidney can't excrete phosphate, leads to hyperphosphatemia, and FGF23 rises markedly, contributing to low vitamin D and secondary hyperparathyroidism. The PTH, phosphaturic, vitamin D absorptive, FGF23 phosphaturic or anti-vitamin D framework is correct. Which statement is correct? A 30-year-old woman comes for cervical cancer screening. This question targets the screening, PAP, and HPV and prevention, not the E6 and E7 mechanism. Read the command. Which cervical screening statement is correct? PAP, cytology, detects CIN or dysplasia, pre-invasion, plus or minus HPV co-testing. Abnormal leads to colposcopy, high-risk HPV 16/18. Vaccine prevents. This revisits cervical cancer from the screening or prevention angle. The pap smear cytology is the cornerstone of screening. It samples cells from the cervical transformation zone to detect DYS pielacia or cervical intraepithelial neoplasia, CIN, PRE, cancerous changes before they progress to invasive cancer, allowing early treatment. Modern screening often adds HPV-CO testing or primary HPV testing to detect high-risk HPV DNA. Screening typically starts at age 21. The correct answer is C. The workflow and prevention are high yield. An AB normal PAP and HPV result leads to colposcopy with directed biopsy wide to confirm and grade the lesion. High-grade lesions are treated, e.g. LEAP or excision, to prevent progression. Causation: nearly all cervical cancer is caused by persistent high-risk human papillomavirus, especially types 16 and 18. Therefore, the HPV-VACCN, which targets the high-risk types, prevents most cervical cancer when given before exposure. It is preventive, not a treatment for existing disease. The combination of vaccination plus PAP and HPV screening has dramatically reduced cervical cancer incidence and mortality. The PAP detects pre-cancer, HPV-driven, vaccine-preventable screening framework is correct. Which statement is correct? A patient on lithium for bipolar disorder is monitored. This question targets the chronic side effects and monitoring, not just acute toxicity. Read the command. Which lithium statement is correct? narrow index, monitor, nephrogenic DI, hypothyroidism or goiter, tremor, teratogenic, Epstein. Renally clear, dehydration or NSAIDs or thiazides or ACEI, raised levels. This revisits lithium from the chronic side effect or monitoring angle. Lithium is a mood stabilizer, first line for bipolar disorder, with a narrow therapeutic index, so serum levels must be monitored regularly. Its chronic adverse effects are high yield and cluster around the kidney and thyroid. Renal, lithium causes nephrogenic diabe insipidus. It makes the collecting duct resistant to ADH, leads to polyuria, polydipsia, and dilute urine, and can cause chronic interstitial nephritis. The correct answer is A. Thyroid lithium inhibits thyroid hormone release, commonly causing hypothyroidism and goiter, monitor TSH. Other effects are fine tremor, weight gain, acne, and in overdose neurotoxicity. It is teratogenic, associated with the Ebstein anomaly, a cardiac malformation, so it is avoided in pregnancy. Crucially, lithium is cleared entirely by the kidney and handled like sodium, so anything that reduces clearance, raises levels, and risks toxicity, dehydration, or volume depletion, NSAIDs, THID diuretics, and ACEE inhibitors all increase lithium levels. The narrow index drug with nephrogenic DI, hypothyroidism, teratogenicity, and renal clearance interactions is the correct lithium profile. Which dimorphic fungus is responsible? A gardener or farmer develops a painless papilla on the hand that ulcerates, followed by nodular lesions ascending along the lymphatics of the arm, ascending lymphangitis after being pricked by a rose thorn or handling sphagnum moss. Read the command. Which fungus? Gardener, rose thorn, ascending, nodular lymphangitis. Sporothrix schenckii, rose gardener's disease. This is sporotrichosis, caused by Sporothrix schenckii, a dimorphic fungus, mold in the environment at cool temperatures, yeast in tissue at body temperature, appearing as cigar-shaped yeast. It lives in soil and on plant matter, classically ROZ, thorns, hay, and sphagnum moss, so it affects gardeners, farmers, and landscapers. Rose gardener's disease. The correct answer is D. The infection is acquired by traumatic inoculation. A torn brick or splinter introduces the fungus into the skin. The classic presentation is LYM for cutaneous, an initial painless papule or ulcer at the inoculation site, followed by a chain of subcutaneous nodules that develop and ulcerate ascending along the lymphatic channels draining the area, ascending or nodular lymphangitis. It is usually local in immunocompetent hosts, can disseminate in the immunocompromised. Treatment is itraconazole, an azole antifungal. Potassium iodide, Ki, is a classic older treatment for cutaneous disease. The rose thorn inoculated ascending lymphangitis dimorphic fungus is Sporothrix schenckii. Which HLA disease association is correct? An immunology student studies how certain HLA-MHC types are linked to specific diseases. Read the command. Which HLA disease association is correct? B27, spondyloarthropathies. DR3 and DR4, T1DM. DQ2 and DQ8, celiac. DR2, MS and SLE or good pasture. B8, Graves. DR5, Hashimoto or pernicious anemia. Certain HLA-MHC alleles are statistically associated with specific, often autoimmune diseases. A high-yield list. The most famous is HLA. B27 is a class I allele. Linked to the seronegative spondylorth. Thupathies, the pair, psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, associated arthritis and reactive arthritis, and anterior uveitis, and interior uveitis, and anterior uveitis. The correct answer is C. The major class 2 HLA-DR and DQ associations, HLA-DR3 and DR4 leads to TYP1 diabetes and DR3 with other autoimmune endocrinopathies or SLE. HLA-DQ2 and DQ8 leads to celiac disease, essentially necessary for it. HLA-DR2 leads to multiple sclerosis, SLA, Goodpasture syndrome, and narcolepsy sclerosis, SLA, Goodpasture syndrome, and narcolepsy. WGB8 leads to Graves' disease. HLA-DR5 leads to Hashimoto thyroiditis and pernicious anemia. HLA-A3 leads to hemochromatosis. These associations reflect how MHC presentation of self-antigens influences autoimmune susceptibility. They're risk markers, not deterministic. The B27 spondyloarthropathy, DR3 and DR4 type 1 diabetes, and DQ2 and DQ8. Block 40 is done. Let's review the 5 biggest traps from this block. Trap 1. Osteoblast control osteoclast. Rankle from osteoblast activates osteoclast to resorb bone. Osteoprotegerin is the decoy that blocks rankle. Estrogen restrains osteoclasts, and denosumab is an anti-rankle drug. Trap 2, above the pectinate line, is endoderm, visceral and painless, portal drainage, internal hemorrhoids, adenocarcinoma. Below is ectoderm, somatic and painful via the pudendal nerve, systemic drainage, external hemorrhoids, squamous cell carcinoma, inguinal nodes. Trap 3, the beta cell co-secretes insulin and C-peptide in equal amounts. High C-peptide with hypoglycemia means endogenous insulin, insulinoma or sulfonylurea. Low C-peptide means injected exogenous insulin, factitious or overdose. Trap 4. Epidural hematoma is arterial from the middle, meningeal artery, lens-shaped, doesn't cross sutures with a lucid interval. Subdura is venous from bridging veins, crescent-shaped, crosses sutures, common in the elderly and alcoholics. Trap 5. Actinomyces is anaerobic, not acid-fast. Normal oral flora, lumpy jaw with sulfur granules, treated with penicillin. Nocardia is aerobic, partially acid-fast, from soil. Pulmonary and CNS disease in the immunocompromised, treated with sulfa. Block 40. 800 questions in the bank, train process, not memorization. StepLogic, learn how to think, not memorize.